TopMedTalk.
Welcome to TopMedTalk. I'm Desiree Chappell, and we're coming to you from the 5th Collaborative Clinical Trials in Anesthesiology meeting here in Prato, Italy. And it's all about big clinical trials going on through the U.S., and it's a big think tank, really, of all these individuals that are involved. I'm joined by Monty Mythen, who's part of this think tank here, and I think this is his second year at the meeting. Monty, what is your thoughts so far?
Well, it's just been fantastic. As I said, second time here. It's run every 2 years. It's a global endeavour run by Monash University from Melbourne in Australia, who happen to have real estate here in Prato in Italy, just north of Florence. It's by invitation only, so almost everyone in the room has been active in conducting clinical trials or in communicating clinical trials. It's a very, very special event. We've heard lots of great results so far, and we can't share them with anyone because they're all embargoed.
It's really tough, and I'm always worried that what I'm going to say, that I might accidentally say something that's wrong, but good thing it's a podcast because we can cut that out, which is good. So we've had, we sat down and kind of went over day one and some of the trials that were discussed in day one, and one of those was the Balanced trial, and specifically talking about delirium. And the presenter was Lis Evered, and we've had a chance to sit down with her. She is a professor at St. Vincent's Hospital in Australia. Liz, thank you for sitting down with us.
Thanks very much, Desiree, and thanks, Monty, for inviting me to talk with you today.
Liz, we just said everything's embargoed, and we know that. We feel like we're kind of walking on eggshells just a little bit when we would discuss it. But can you just give us a little bit about maybe the trial design and some of the things that are coming out of and some of the things that you can say that you presented yesterday?
One of the things about delirium is that there's a lot of work that's been looking at depth of anaesthesia and whether or not there might be an impact of depth of anaesthesia on the incidence of delirium. There's been a few studies looking at a targeted BIS compared to routine care, but when the Balanced study was started a number of years ago, it became an opportunity to look at what the incidence of delirium might be in two groups that were both targeting a high and a low BIS. So a much more robust comparison because the groups are going to, we knew the groups would achieve a good separation. And so we set about setting up a protocol to look at delirium incidence in the randomized controlled Balanced study. And so those groups are targeting a high BIS of 50, so patients with relatively light anaesthesia, compared to a lower BIS, so deeper anaesthesia, of 35. And so, that for us was a perfect opportunity to put some sites on who were interested in undertaking the training to assess for delirium so that we could see if there was a difference.
Delirium's your thing, right? You're kind of an authority in the world right now on delirium. And so when you were designing this and looking at this trial, what are some of the rates of delirium right now that what you were expecting out of the study?
In Australia, in our institution, we see an incidence of delirium of about 43% following cardiac surgery and about 36% following non-cardiac surgery. So we're talking about a really a significant proportion of patients 65 years and more who end up with an episode or more than one episode of delirium that we know has long-term complications, increased mortality, increased morbidity, increased risk of dementia and further cognitive decline. So it's a really important poor outcome. And we know that there's a possibility to prevent some delirium, so it really is important for us to really start mandating that patients are assessed preoperatively. And I think until we establish clearly what the incidence is and things like perhaps lighter anaesthesia may be protective. In the work that's been done up until now, it's equivocal between the studies that have been done. There's no clear evidence that that lighter anaesthetic might be more protective deeper anaesthesia.
Liz, we see plenty of delirium, so I'm exposed to it clinically on a regular basis, but I've also had some exposure to the challenges of measuring, quantifying delirium in the patients. How are you able to standardise that in a multi-centre trial and make that measure robust and reliable?
So the really nice thing about the tool that we used, which was the 3-minute diagnostic CAM tool, confusion assessment method, is that it's part of some work that Sharon Anui and Ed Marcantonio have been doing on the HELP delirium that they've been working on for many, many years. And there's a website where they make available for trial purposes and clinical purposes an opportunity to undertake a formal training. So that's done online. There are videos. It meant that we were in a position where we were able to standardise the training that everyone, no matter which site they were at around the world, was undertaking exactly the same training. And I centrally scored all of that and fed back to each of the individuals who were training where there was any errors, where we needed to repeat any of the training processes. And we, at each site, would have consensus meetings if we were a little concerned about how the coding should go. So the website that has made that training available is phenomenal, and we couldn't have had that's the only way we were able to have a standardised assessment protocol.
Is that a website available just publicly? Can anyone use it? And if it is, can you share that with us? Because I think there are a lot of providers that would be interested in standardizing what they're doing in practice.
The website is called the Hospital Elder Life Program website. There are a huge number of resources for healthcare practitioners and certainly for patients as well, people who've perhaps experienced an episode of delirium and would like more information. As far as the training tools are concerned, you have to apply online through the website in order to be given access to the training videos. Mostly that's for non-funded or non-sponsored trials. That they'll make those available at minimal or no cost.
That's a great resource to have, because a lot of people are trying to do, even smaller studies in the area of delirium and cognitive dysfunction. And I don't think that I'm overstepping the boundaries, because I'm not going to ask you about it specifically. But we talk a lot about brain health and delirium and associated with anesthesia. I know that you were just looking at the rates of delirium and the level of anesthesia or depth of anesthesia. But were you able to look at other factors that affected, hemodynamic management or anything like that? Or are you taking a look at those specific aspects?
So we definitely will be. At this point in time, the results that I presented yesterday were very preliminary results and just the main primary outcome. But we certainly have a large database of information. We will need to go through and look at the comorbidities that those patients were experiencing, the vulnerabilities that they brought, and in particular their baseline cognitive function we know that patients who have subtle cognitive impairment are at greatly increased risk of having an episode of delirium. So for this study, we used the mini mental state examination to assess baseline cognitive function, and we also assessed that at discharge from hospital, and we used a phone, a tool that can be used over the phone to measure cognitive function at 1 year. So all of those factors, and then as you said, all the intraoperative factors, the level of vasopressors used, pain, how many opioids the patients got, whether or not any of them had benzodiazepines, and certainly all the hemodynamic variables in the intraoperative period will be taken into account.
Relatively recently was published, as was touched on in the presentation, was the ENGAGES trial, which is as I understand it, a single-centre US trial that superficially has some subtle differences, but as you get into it, has some really quite marked differences in trial design. Could you just comment for a moment on that?
One of the major differences with the Engages trial is that they only assessed delirium once daily, and they did that in the afternoon, whereas for the Balanced sub-study we assessed delirium twice daily, in the morning and in the evening. So the assessment of delirium relies to some extent on the tool that you use and the frequency of your assessments. So we did both use the same tool. The Engages study used the 3D cam, the same that we did. One of the, I think, in my opinion, the concerns about the Engages trial is that both groups had periods of time where there was burst suppression, and both groups had periods of time where the BIS was below 40. So talking about both patients in both groups being exposed to burst suppression and really deep anaesthesia. And what we don't know at this point is whether there is a threshold for those things. Is a little bit of burst suppression okay, but a lot not okay, or is the fact that you're in burst suppression at all a problem? And that's what we'll be looking at with the data that we have.
Excited to see those results. When do you think those are going to be coming out in your estimation?
We would hope to get this published by the end of this year, certainly. I would hope. So, yeah.
Good luck on that. Liz, I know we need to get back into the next session, but I was dying to ask, I know you participated in the BJA, the British Journal of Anaesthesia's Women's Symposium here in Prado a couple days ago. And I know there was a lot of good conversation that came from the meeting. I just kind of wanted to get your take on it. I know that you were going to participate in a panel and they kind of ran short on time. But what was your kind of big takeaway from the symposium and this gathering of women?
Thanks, Desiree. It was a really interesting meeting. It was great to have some really empowered, high-achieving women presenting to us. I guess the thing that I find really important about that is how aware we need to be about any sort of minority group and making sure that we pick the best person for the role, whatever that might be, a job, a promotion, speaking at a conference, no matter who that person is. And so if that's a woman is the best person for the job, then that's great, and that should be how we move forward, I think. But taking into account all sorts of minority groups, people that sometimes you don't know what people's backgrounds are, and we talked a bit about that on Tuesday afternoon, that we see people at the level they're at, they've achieved all these wonderful things, and sometimes you just don't realise where people have come from and what sort of discrimination that they have been have faced in order to get to where they are. The sort of
bar, I wasn't at the session, arrived a little bit late, but the bar chatter is quite mixed about the. They all agree with that it's an important issue and it needs discussing, but there's quite a spectrum of opinions from people. Did anyone play devil's advocate in the session, or was it possibly loaded one way?
I felt it was a bit loaded one way. As Desiree said, there was meant to be a panel, and I was gearing myself up to play devil's advocate. I think we need to be really careful that we don't end up with tokenism. We need to make sure that women are appointed to promotions or get invited to speak at major conferences because they're the right person for the job, not just because they're a woman. I think we need to be really careful that we're applauding women for the right reasons.
We've had 2 female prime ministers in modern times in the United Kingdom, and both of them have been taken down by the predominantly male colleagues around them. Do you think there's any messaging there, or am I reading too much into that?
Wow, really interesting. Next we'll be on to religion. Politics. Look, in my opinion, and I'm not the greatest with the world of politics, I'm not the greatest with Australian politics, but I think that would be reading too much into it. I think both of the UK prime ministers who've been women have been in their positions for a long time and have been very powerful
I've only felt like a collaborative relationship in a lot of in everything that I've done, and been very supported very well by women and men. And I think going forward, that's always important to kind of look at that aspect. I mean, you're always going to look at the people that didn't want you to succeed, or they were discriminating against you. But there are so many more people that are usually for us as women, or a diverse group. So
yeah, look, I completely agree with that. I've been incredibly fortunate in my career to be given amazing opportunities by women and men around me, and I've been fortunate to be in such a supportive environment for my career.
You've done amazing things, Liz. Congratulations on all the work that you've done and been doing, and that I know that you're going to be looking at and continuing to do. And I think it's a good message. For sure. So thank you so much for taking the time to sit down. I also wanted to make a plug that we just had some lectures that went out on TopMedTalk a couple of weeks ago on Sunday Special on the perioperative SIG, or shared interest group meeting that you presented on perioperative cognitive dysfunction. And it's a fantastic series, so I please encourage everyone to take a listen, and hopefully we can talk to you soon. Thanks so much.
TopMedTalk.
Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.